Greetings, I'm Dr. Chan, neuropsychologist in Miami, faculty at Pepperdine University, and the founder of the Center for Neuropsychology and Consciousness. Welcome to the CNC interview series. My next guest is Dr. Barry Nierenberg. He is the President's Distinguished Professor at Nova Southeastern University, a board-certified rehabilitation psychologist, and one of the past presidents of the American Psychological Association's Division of Rehabilitation Psychology. He is the recipient of numerous prestigious awards, has published several papers, and presented both nationally and internationally. In this interview, we begin by defining what rehabilitation psychology is and common challenges people face within this discipline. We talk about hope, how it may be operationalized, and its importance for coping with life-altering changes. We subsequently discuss resilience and well-being therapy in the context of rehabilitation psychology. The topic then transitions to pain and how to properly define it, as well as how to treat and cope with chronic pain. He shares novel treatments with very strong outcomes that do not require medications. We further touch on special topics before landing on meaning and spirituality. Feel free to skip around if there are any topics of particular interest to you. What is rehabilitation psychology and how is it distinct from other types?
That's actually a really good question. As some people know, Rehab Psych was formed after World War II because they found that, especially after the Korean War, because the soldiers in theater who used to die from their injuries, given the increase in medical technology, they were living. But we found that back then that a lot of how you were doing was not only the biological injuries, but also how it affected you in what we now know as the biopsychosocial realm. So we started rehabilitation psychology because the way in which a soldier or anybody is going to be functioning a year after an injury is very much a function of the meaning that they're bringing to it. So not unlike what Viktor Frankl talked about in his books, about the really critical role of meaning.
Right.
And then later in the 70s is when health psychology came on board. And both specialties are recognized by the American Board of Professional Psychology because they have distinct cultures, distinct backgrounds, and distinct focuses. So rehab is really a focus on those biological conditions where there's no cure. You have to live with it. So it's really about what do you bring to the table and what does it mean to you and the people who love you.
Wonderful. Yeah, so just to clarify, when some people think of rehabilitation, their mind automatically goes to rehabilitation from alcoholism and other sorts of substances. In this case, we're really talking about a specialization with injuries, perhaps from a traumatic brain injury, from a spinal cord injury, chronic pain, some of the topics we'll delve into. But this question of meaning to me is something I wanted us to hone in on a bit. Now, you gave a TED Talk and you spoke about some of the things that you learned from your patients, further developing a map of sorts to help people prevail in the face of suffering. This includes things like the what, the why, the how, confidence. I'm wondering if you could give us a short form description of what you talked about there.
Yeah, sure. And that's really my take on Snyder and Lopez's idea about hope. And I applied that to rehab psych. So what they said about hope is you really need three things. And especially this is articulated by Shane Lopez in his book, Making Hope Happen. So I like to give credit where credit is due. So what he said is you need three things to have hope. First thing is you have to have a goal that's measurable. That's how you know when you got there. Second thing you need is a pathway to that goal. which is the how. And then you also need what what they refer to as there's different ways of understanding it, but it's really having faith and confidence in your ability to reach that goal.
Mm-hmm.
And when you have all three, he says you have hope. And he makes a sharp distinction between that and optimism. Because optimism, he says, is when you only have one pathway. And when that idea inevitably hits a speed bump, you are up the creek without a paddle, so to speak.
Mm-hmm.
That's why you need multiple pathways about how to get there.
Mm-hmm.
And the why part is really gets back to Frankl, who famously said, those who have a why can get through any how.
Mm.
So how am I going to continue? Well, you need a why and you have to have meaning.
Right. Yeah. I think Nietzsche had some influence there as well.
Exactly.
But yeah, Frankel's methodology was wonderful. So here we have the why, the how. We have hope. This idea of hope, which is clearly very important in rehabilitation psychology. So, in the example of an athlete, for example, who loses a limb and is no longer capable of enjoying what their previous passion was. This idea of hope is extremely important. The other thought that comes to mind is this notion of resilience, now that you've broken down what hope is. And I guess I wanted to get your take on resilience. I know that there have been some studies looking at different, for example, personality traits related to resilience, higher extroversion, agreeableness, conscientiousness, emotional stability, and openness to experience that sort of thing. Um, but I'm wondering from a rehabilitation perspective, I'm wondering if you could give us a more nuanced, maybe definition of resilience and, what you found out have or what are some other commonalities you found in people who you found to be resilient.
That's a wonderful question. And it really gets to the heart of what it's like to live with a condition that's disabling.
Mm-hmm.
There are a lot of ways to understand resilience.
Mm-hmm.
And you articulated one of them, which is very research based and what the evidence shows.
Mm-hmm.
In a more theoretical vein,
Mm-hmm.
what I use to understand it is the first rule is to not try to instill resilience or a version of resilience, which is post traumatic growth,
Mm-hmm.
because those things are linked. So, the way I understand it in two different ways. The first way is some of the grandmothers of rehab psych. So, way back in the day, Tamara Dembrow talked about the difference between succumbing and coping. Right? And succumbing is now understood as a passive reaction. So you're in a car accident, something bad happens to you, you have a stroke, or you love somebody who's been in a car accident or has a stroke. It's really easy to um, be impressed with what you've lost. And if you get stuck in that space, you're succumbing and you could feel helpless and hopeless, as opposed to what are the conditions under which you can actively cope. So, some of the foundational principles that were laid down for rehab psych is no amount of physical disability erases your assets as a person. So, the trick is to, if you are mourning your losses, and you don't have to, but if that's a space you're in, absolutely. No one's going to argue, I'm glad I lost my leg. I'm glad I had a stroke.
Mm-hmm.
Even if there is a silver lining in the dark cloud, it's still a dark cloud.
Yeah.
So, in addition to feeling the loss of what you had and now you may never get back, it's also important to appreciate what you still have and how that affects your purpose in life as well as your meaning. So what I use for resilience is there is a strong correlation between resilience and well-being. Right? It's hard to be resilient if you have a deficit of well-being.
Yeah.
Right? And I've been very impressed with Carol Riff's work, RYFF. And Carol, since the mid 80s, has been the director of the Center of Aging up at University of Madison, Wisconsin. And back in the late 80s and 89, she articulated an evidence-based articulation of what well-being is made up of. And she talked about 6 different factors that I can get into if you like. But it's these factors, things like purpose in life, having having good connections to other people, etc. And the more you have of those 6 factors, the higher your well-being can be. So by looking at which, and she has a wonderful questionnaire, which is very reliable and valid and for free, about how to measure the well-being. So once you can measure it, then you're in pretty good shape. And one of her previous collaborators, a guy by the name of Giovanni Fava, put together well-being therapy, which is geared towards increasing people's functioning on the RIF 6 factors.
I see. Okay. That was definitely what I was going to circle back to.
Right.
Well-being therapy. But
Oh, yeah.
let me take a step back. So when it comes to increasing or helping someone, let's say, achieve a higher level of resilience, right? I think you were about to launch into perhaps what you might do to help somebody out.
Yeah. And it's really a variant of the well-being therapy.
Okay.
So one of the things about well-being is that they found that there is an almost perfect negative correlation between high states of well-being and negative emotions.
Mm.
So when well-being is high, your negative emotions are low,
Mhm.
and vice versa. So one way to understand a lack of resilience
Mhm.
is that's related to depression and anxiety.
Mhm.
If you have a lack of resilience, someone once described depression as an inability to bounce back the way you used to.
Mhm.
In other words, your resilience is shot.
Mhm.
So, one way to understand those people who are succumbing, those people who are hopeless, helpless, and depressed after having an acquired disability or a congenital one, um, for that matter. One way to understand what they're going through is not necessarily as, or not only, as the presence of depression or anxiety. But what Riff and her colleagues found is that it can be extremely helpful to look at it as a deficit of well being,
Mm.
especially given the perfect negative correlation.
Right.
So if you can increase someone's well being,
Mhm.
that can affect their depression. So Giovanni Fava did a brilliant series of studies.
Mhm.
So he was looking at this, and when he was trying to develop well-being therapy,
Mhm.
he said, "Look, Let's start at the very beginning, right? People who have major depression, the recidivism rates are terrible. You had one episode of major depression, there's a 70% chance you're going to have a second one.
Mm.
And if you had a second one, there's an 80 to 90% chance you're going to have a third. And if you had a third, 100% chance you're going to keep getting them.
Hmm.
He said that makes no sense. If that was cancer, right?
Mm-hmm.
And your surgeon, your oncologist came to you and said, good news, right? I got rid of the tumor. Bad news is a 70 to 80% chance it's going to come back. That's not something you want to hear.
Mm-hmm.
So he said, look, because that doesn't make logical sense, if you eliminated the depression, why does it keep coming back?
Mm-hmm.
Which is, I think, a great question. So he said, perhaps it's not the presence of depression because you got rid of it.
Mm-hmm.
Perhaps instead, it's the absence of well-being.
Mm-hmm.
So he did several studies. First one, he took a group of people who were boringly normal and never qualified for anything in the DSM or the ICD, mental health diagnoses. So he took those as a control group. Then he took a group of people who were recovering from and in remission from major depression. Split them in half. Half of them treatment as usual, and half, in addition to treatment as usual, got 8 sessions of well-being therapy. It was 30 to 50 minutes. It was based on CBT because most of them already had CBT. And the difference in well-being therapy when you use a cognitive approach a la Fava is that instead of focusing on dysfunctional thoughts, he focuses on the ways in which you turn off your well-being. So one of his examples was a grandfather who's seriously depressed. And Fava would ask him and everybody who gets well-being therapy, tell me about, I want you to log and have a diary of those brief, fleeting moments when you're happy. Because even if you have major depression, by accident, every once in a while, you're going to be happy. So Grandpa said, when my grandchildren visit, I'm happy. He says, okay, tell me about it. What happens? So they come in, they hug me, we love you, Grandpa. And I give them a present, and they're all thankful, and it's just warm and wonderful. He says, okay, then what happens? He says, well, then I start to think, you know what, maybe they don't love me. Maybe it's just they like getting presents and money, and, I'm just a piggy bank to them. I'm nothing, and then his depression comes back. So Fava, through well-being therapy, worked on the usual kind of things we know and love. It's like, what else can be true? How do you know it's true? What's your evidence base? Right? So what he found is that immediately pre-post on Riff's well-being questionnaire, their well-being went way up, right? Just from 8 sessions every other week. Right? So 8 sessions of this well-being went way up. But Fava being Fava, he was not happy with just that. And he teaches at the University of Bologna in Italy. And in Italy, unlike here in the States, people are quite provincial and believe wherever they live is the best place in the world and they don't move. Right? So he was able to contact almost everybody in his original study 6 years later. And he looked at the recidivism. Oh, by the way, immediately afterwards, pre-post, the group that got his well-being therapy, their well-being was indistinguishable from the control group. That's how high it went.
Yeah.
So he contacts him 6 years later. He looks at the recidivism rates for the treatment as usual group versus those who got his 8 sessions 6 years ago. Turns out the treatment as usual had the usual recurrences of around 80% recidivism. His experimental group, 40%.
Wow.
Exactly.
Yeah, that sounds like a very powerful therapy, and what a dream for researchers in longitudinal studies to be able to
Exactly.
find all their subjects again.
So, along with some of my students, I published an article on well-being therapy for people with disabilities way back in 2016.
Hmm.
And that's how I argue and I work
Okay,
with increasing people's resilience.
excellent. So
So,
Barry, just
marrying that to the rehab psych principles,
mhm,
no amount of physical disability erases your assets as a person. It's like,
right.
what else is true? What
Hmm.
happened to you stinks. It's horrible. What else is true?
Hmm. Hmm. So, um, so I guess the first thing that comes to mind also, that value, does that come from Beatrice Wright's work, the
Yeah,
2030?
absolutely. That's the foundational principles.
Hmm.
And she wrote the Bible back in the early 80s, and she had 20 foundational principles. And the last one of which was these are not handed down from Mount Sinai by God, right? And, they're very excellent in the early 80s, but people should revisit them. Um, she died a few years ago at 101. But before she died, um, one of her um, um, close colleagues, Dana Dunn, was able to work with her, and she kind of anointed him with doing the follow up. So in 2016, he published a book called The Social Psychology of Disability, which is really the follow up to Beatrice Wright. And what he did is he distilled the 20 principles down to six. And we recently added a seventh, which is advocacy.
Mm. So I was wondering if we could get a little more, uh, because, well, let's take a step back to well-being therapy, actually.
Sure.
Um, we don't have to go into every single factor, but I was wondering if you could just list them off for myself as well as the listeners, if you remember all of them.
Yeah, sure, I can. In no particular order,
Yeah.
because um, the ones that will be in the foreground, the ones that will be in the background, um, are somewhat idiosyncratic in what Carol has found over 40 years is that um, the ones that are important to you change as you age.
Okay.
So, in no particular order, one is what she calls self acceptance, which is the ability to see and appreciate your strengths and your weaknesses. Also, in terms of what you can improve on if you work hard enough in the future, and what you can't improve on, and be comfortable with all of it. Then there's purpose in life. What gets you up in the morning? What gives your life meaning and direction? Then there's personal growth, which is a feeling that you're more of who you need to be than you used to be. And then there's positive relationships with others, which is critical. In fact, in all of the well being literature, that's the most important, is having people close to you that um, you feel comfortable with and who feel comfortable with you. Then there's environmental mastery, being able to manage the everyday demands of life. And it doesn't mean you do it yourself, it means you know who to go to if you can't. So um, if I have IT problems, I call my IT people. Or, like you probably, easier to get hold of my students who are much more able to handle IT stuff than I am. And then finally is the existential idea that you know and love about autonomy, which is the courage to do what you think is correct. You know, kind of the old idea about the Ubermensch,
Mm,
um, and Maslow's self-actualization.
I see.
So those are the six.
Excellent. Thank you for sharing that. So this is a lens through which you sort of peer through and operate through when you're working with clients or patients who are suffering from disability. Um,
It's not only suffering; it's living with it.
right.
And some days it's a stereotype that
Mm,
we all fall into. That God, if you have a disability, you must be suffering.
mhm,
No, because that's what Dana Dunn refers to as the insider-outsider distinction.
mm,
So to us, who are at least temporarily able-bodied, you look at someone in the wheelchair and you think, Jesus, I don't think I would do very well if I was in a wheelchair. They must be suffering. But to the person, it's just like it's one more thing.
right.
You know, like I don't think about wearing glasses. Just one thing about me.
Yeah. It's something that's a bit of a myth, right? People tend to underestimate the extent to which people can actually cope and adapt to challenges that they may see in their current perspective as something that they would be unable to get over, perhaps. But lots of people bounce back and, in fact, possibly thrive, hence even the term post traumatic growth and such.
I'm glad you brought that up because all the literature on well-being shows that we have each of us has an idiosyncratic set point, which may temporarily deviate
Mhm.
if you have something wonderful happen to you, you win lottery, or you have a baby, um, and uh, the same is true on the other side. If something terrible happens to you, after 3 months, you pretty much go back to your set point.
Right. It's interesting. 3 months. Hmm.
Yeah.
Okay. I didn't know the number. Good to know. So, one of the populations I wanted us to jump into is very much people who suffer from, or not suffer from, but we'll say people who are working through maybe, or uh, working through chronic pain. Okay.
Yeah.
And I was wondering, maybe we can start off by, you can help us start off by untangling the difference between maybe chronic pain and other types of pain.
Yeah. I don't remember who said it, but one of the pithy remarks about it that I remember
Hmm.
is there is absolutely nothing worse than knowing that your terrible pain will still be there tomorrow.
Hmm.
That is a difficult, difficult way to live.
Hmm.
I can go 50 different directions. So it's rather than have me prattle on, it's like,
Okay. So, one of the things that, for example, when I work with someone who's going through chronic pain, one of the things it's so embedded in my own language,
right? Everybody's.
but it's funny because uh, I don't actually believe it, but it's a narrative that's like an automated script because I have worked with a fair amount of people who are going through such things, and lots of them end up being far more resilient and just, I guess you're right, the word suffering is so just embedded in our culture even that it's sometimes hard to disentangle. But I diverge. So with chronic pain, some people who I work with, what we can end up doing is, for example, distinguishing between clean pain versus dirty pain. Right, this idea that there's the, the exact sensory experience of pain, and then there's also the dirty pain, quote unquote, which is the emotional narratives or scripts, like I just shared with you, that they might have that may um, exacerbate or amplify the pain states that they find themselves in, and then by distinguishing and developing a clearer perspective of the two, we begin being able to change the narratives that may come post the feeling or sensation of pain itself. So, I know that you've already introduced, well-being therapy, the six factors and such, but Maybe you can share with us what are some things you do with people who have chronic pain.
Great timing.
Hmm.
I just gave a pain lecture
Perfect.
to, to the one of my classes.
Hmm.
So if I had to distill down a 3-hour lecture, um, there are a number of critical points that you raise, and your experience is showing in your question.
Hmm.
Um, First thing is that the International Association for the Study of Pain um, is the group that's responsible for the accepted interprofessional definition of pain.
Hmm.
They first came up with their definition in 1979, and um, one of and they talked about it in terms of an unpleasant feeling with physical and emotional components for real and or potential tissue damage.
Hmm.
They found in 2018 um, that that was an excellent start, but it no longer respected some of the newer neurobiological findings um, that people have come to understand around chronic pain. So they went through a 2-year process of coming up with a new definition. And the new definition, I think, does an admirable job in addressing the deficits of the old one. Because one of the deficits of the old one is it's easy, especially for our medical colleagues who are well entrenched in the biomedical orthodoxy,
Hmm.
that either um, your pain is real, meaning I can appreciate the tissue damage and I think you should be in this much pain, or I don't appreciate the tissue damage and I don't think you should be in this much pain, in which case it's emotional and you need to go see a shrink. And as you know, when those people, if they show up in our office, a lot of times they don't. What they do is they just switch physicians because they're so angry. If they do show up in our office, they double down on their pain behaviors because, my doctor thinks it's in my head, but it's not in my head, it's in my back. Um, and the new definition says it's an unpleasant experience with cognitive, emotional, and social aspects. So all of the literature shows that unless you understand, evaluate, and intervene in chronic pain along a biopsychosocial model, you're going to get nowhere because all of them interact. Um, so basically, it's now understood that it's unfortunate that we call the nerves responsible for telling us we're in pain. It's unfortunate we call them pain nerves because they're not pain nerves. The technical term is nociceptive nerve. And the reason why that's important, even though nociceptive to a lot of lay people is nothing but a good Scrabble word, the reason why it's important is if we take every other nerve that communicates sensory data to the brain, let's take the optic nerve, right? Your eyes are um, exquisitely designed to take light frequencies, translate them to electrical frequencies, and then through the optic nerve, transmit that to your occipital lobe, where your occipital lobe is the CPU that gives meaning to these electrical impulses. We do not call the optic nerve the seeing nerve because you don't see with your optic nerve. In fact, you don't even see with your eyes. For those people who have a brain injury or a stroke, and if it significantly affects the occipital lobe, you are cortically blind, even though your eyes are working fine. The problem with calling the nociceptive nerves the pain nerve is that that has the connotation that's the nerve that tells you you're in pain. And it's not. What that does is very simply, it transmits information about thermal and mechanical damage through the spinal cord, up through the thalamus to the somatosensory cortex. Once it leaves the somatosensory cortex, where it goes and how it's understood is very much a function of what the person has learned about pain. And through the non-pharmacological interventions, which have an evidence base, we've learned that we can teach people how to reroute that nociceptive signal after it leaves the somatosensory cortex. So, for example, for those individuals who have a low pain tolerance and catastrophize, what's been shown, no surprise, is that when the message leaves the somatosensory cortex and the brain is asked to make sense of these nociceptive inputs, if it goes through the amygdala, travels through the anterior cingulate cortex to the frontal lobes, you can get depression, anxiety, and catastrophic thinking. Well, that can be rerouted. And the evidence base that I am most impressed with, there are two. The first one is way back in 2012. Mark Lumley, who's a great guy. I've met him a couple of times. What Lumley did is he looked at the people who have chronic pain. And he said, what do they have in common? And one of the things he found is that for those people who have low-level depression, anxiety, or moderate levels of depression, anxiety, or undiagnosed depression and anxiety, and for those people who do not have a strong emotional vocabulary, right? So even amongst our, not so much our colleagues, hopefully, but our friends and family, there are those people who have exquisite emotional vocabularies, especially musicians, right, who can really put it out. There are other people who we may know and love who their emotional vocabulary is reduced to, I feel good, or I feel bad, period. Now, for those people who have limited emotional vocabulary and limited ability to identify different feelings, if they have an injury and they get prescription opioids from a well-meaning physician, or they have surgery and they have prescription opioids, one of the side effects of opioids is intoxication and euphoria. So they feel great. And they conflate their emotional pain with their physical pain. You know why I feel great? Because I got pain meds. And they don't understand that it's the side effect of the pain meds. So they come up with what I've heard often is opioids are my friend. Right? And why would I want to give them up? So to stay focused, which is hard for me. Lumley, I want to go off in all kinds of directions. Lumley said, okay, if I found this as one of the commonalities amongst people who get caught up in problematic opioid use after a prescription from a physician, he said, if that's the underlying structure, then what would happen if I increase their emotional awareness and increase their ability to better identify emotional states and then act appropriately? So in 2012, he came up with emotional awareness and emotional therapy. EAET.
Hmm.
And his results are excellent. And back in, I'm pretty sure it was 2021, Asher took the ball from Lumley and took it across the finish line.
Hmm.
What Asher came up with, this was published in JAMA.
Hmm.
What Asher came up with is something he called pain reduction therapy, PRT. And what he added to Lumley's work is psychoeducation about what we just talked about. That non pharmacological approaches can reroute the signals.
Hmm. So,
And
may I interject?
yeah,
Where do the signals get rerouted to?
uh, um, if you can go directly to the prefrontal cortex, for example,
Okay.
instead of through the amygdala,
Mm.
you can have constructive thoughts,
Mhm.
right? I know what this is, right? Pain is a signal something is wrong.
Mm.
And as one of my neurologist friends put it, he had a great analogy.
Mm.
So he would talk to people with chronic pain, and he would say, okay, look, here's the story, all right? The good news is that your chronic pain is there. It's real. You're feeling pain. The problem is that it got away from its original purpose. It's supposed to tell you something is wrong.
Mhm.
You already know you have a bad back.
Mhm.
And he said, he came up with the analogy. He said, look, if your system of recognizing pain was a house alarm,
Mhm.
it would be going off for the wrong reasons. It's going off because the wind rattled the window pane, because your dog hit the door.
Mhm.
So that's the first problem. Second problem is your alarm is too damn loud. It's deafening. And the third problem is it goes on for too long.
Mhm.
So what we're going to do is rewire your CPU, rewire your brain to where your pain signals only alert you when something is wrong and new. When it does alert you, the volume will be turned down to where it gets your attention. And once it gets your attention, it will turn off. And so with the Asher's pain reduction therapy, people can say, okay, I can put in cognitions. Or if you're more kinesthetic, I'm going to relax. I can see my back is going out. I'm going to do my exercises. I'm going to take it easy, or I'm going to purposely exercise and stretch. I know how to do this. Um, his results are almost unbelievable.
Hmm.
So he compared um, PRT to treatment as usual to no treatment, to placebo. All right. He also has a very limited, I think it's 6 sessions, but don't quote me on that. It's not a lot,
Mhm.
6 to 8 sessions where he goes through his psychoeducation. He asks people to um, come up with examples of how this might be true in their own life, right? And then how they could handle it better.
Mhm.
He has 70% of the people are nearly pain free or pain free
Hmm.
1 year later.
Wow.
Exactly. It's like, and he has MRIs.
So let me see if I can let me see if I can understand this a little more and get some clarification from you.
Yeah.
So, and also for the people listening. So one thing that we do know, there is a lot of overlap between physical pain and emotional pain. Um, and two regions, for example, for the neuro nerds out there, the ventral medial prefrontal cortex as well as the anterior cingulate cortex, which you actually already mentioned.
Yeah.
Now there's shared neural real estate there, and you're saying that this therapy by modulating emotional awareness, by increasing their ability to label emotions that they're experiencing, they're capable of reducing pain that is usually felt with chronicity. And up
Pain-free or almost pain-free 1 year later.
okay, that's very impressive.
Yeah, Asher 2021 JAMA.
Okay, okay. So I want us to bring this into more of I want to bring this to more practical use for those listening, right? Especially what I just said and what I just summarized you saying. So for someone, let's imagine someone with chronic pain is listening to this right now.
Okay.
Okay. Maybe they don't have the resources to access this therapy, or maybe now they do and they know where to go. But in the meantime, what could they do to potentially reduce some of the pain they're feeling?
That's the crux of the problem.
Mm,
Because there are so many routes
mhm,
um, that lead to an individual experiencing a terrible chronic pain.
mhm,
It depends on how it's routed.
mm,
Um, so, you know, all the stuff: progressive muscle relaxation, hypnosis, distraction,
mhm,
um, um, getting better at labeling your feelings.
mm,
It's difficult though on your own
mhm,
because your brain, your brain is so wired. It's so easy for impulses that are leaving the somatosensory cortex to go straight to the amygdala, the ACC,
mhm,
you know, because that's the well-worn pathway.
mhm.
That's a path of least resistance.
Yeah.
It's hard to change that on your own.
Mhm,
So they need to go talk to somebody. And what's happening nationally is that some of the leaders um, in um, in pain, in psychology,
mhm,
put together a video um, where APA is going to offer pain education
mhm.
for free to every psychologist.
That's a great service.
So, yeah, exactly. So it's hard to do on your own.
Yeah, fair enough.
But what I'd like, if someone's listening, or if someone
Mhm,
is listening and knows someone who's in chronic pain, um, I want them to have to get hope.
mhm,
It is possible to change. It's possible to not rely mostly on opioids. Opioids are a very, very problematic solution because of the side effects.
mhm,
The side effects are not only decreased quality of life, let's forget that, right? The data are not only are you much more likely to die by opiates because you habituate, you have to take more, and the more you take, one of the side effects is decreased respiration, and you're just not going to wake up one day. But also, long term opioid use leads to a condition called hyperanalgesia, where your brain becomes hypersensitive to pain signals, and your pain becomes worse. So, what I'd like those people to accept on faith right now, that we have excellent data that you don't have to live this way. There are alternatives that have, look, the side effect of pain reduction therapy is nothing.
mhm.
You're not going to die. You're not going to get addicted. You could use it as much as you want. The help is out there.
Yeah, it's I think difficult for lots of people to view their, let's say, their internal mental activity as so connected to their bodily experiences, because it can feel so separate, even though we know from the data that they're very connected, right?
That's right.
Another issue I know that you also worked with was PTSD and chronic pain. It was funny for me when I was at the Writer Trauma Center doing my internship there. One of the things that I realized quite quickly, with the people who suffered more severe accidents, the intuition is, oh, they probably are more likely to have PTSD. But for the most part, it wasn't the case because most of them were unconscious when the event
Right.
happened, right? Versus people with more milder conditions or who were conscious while the event occurred ended up, of course, having a higher chance of PTSD. In any case, I was wondering if maybe you could share a little bit about that paper about chronic pain and PTSD.
Yeah. And the connector there for me, as you're insinuating, is the meaning that you bring to it. So the people who had a horrible injury, who were unconscious, I was driving, and next thing I knew, I woke up in the emergency room.
Hmm.
As opposed to there I was fixing a tire, and a car hit me, and I both my legs are amputated. And I remember laying there, and I was thinking I was going to die. That's how you get PTSD.
So, was there a higher incidence rate with PTSD and chronic pain that was found? A positive correlation.
Yeah, yeah. Um, because also chronic pain is very related to comorbid depression and anxiety.
Mhm.
You're depressed that your pain's still going to be there tomorrow because it's been with you for 8 years already.
Right.
Um, and you're anxious that, oh my God, if I move wrong, my back is going to attack me, and I'm going to have a yikes.
Hmm. Yeah, it's scary and kind of sad, disheartening how reality can continue to constrict and constrict and constrict, depending on the narratives that people build in their minds. There is one more thing I wanted to get your thoughts on. It was something interesting that I also found during my time there, and basically the idea was that I guess the first thing, most people don't really consider how vulnerable people are in a rehabilitation setting. Not only are they, stripped of their regular clothes, but in a sense, very psychologically vulnerable also, right? And in that vein, one of the things that I've found was questioning when I would run into people who were quite defensive. It wasn't the most common, but it was not uncommon, we could say, that people might get defensive when you start asking certain questions. Um, but the question that I'm interested in exploring a bit is it a defense or a deficit? Because what I ended up finding was, for example, when I was working with some people with traumatic brain injuries, well, especially with frontal lobe injuries, they were far less, and they were much more disinhibited, to say the least. And so, when they were, for example, saying things that may be inappropriate, it was important not to take it as a defense, and the treatment would be, or interventions would be quite different if it were. So, just wanted to gather some of your thoughts on that. I thought it was kind of an interesting subtlety that could be helpful for students, actually.
Yeah, and the difficulty here, as you're insinuating, is it's complicated.
Hmm.
So you not only have premorbid functioning
Hmm.
and what was going on, but you also have the ways in which your brain has been disrupted and the ways in which it's starting to heal up and recover. So, which um, stage of recovery are you in,
Hmm.
and what are the implications? Um, because you can get stuck at any stage.
Hmm.
So the bottom line is it's critical to do a really rigorous biopsychosocial evaluation
Hmm.
in the broadest sense of the term. Who were they? Who are they? What is it? What does this particular deficit mean to them? So, my favorite example when I'm dealing with students is as much as I love watching basketball, I am constitutionally unable to bounce a ball and walk. I can't do it, right? So, if God forbid I had a stroke and I could no longer dribble a basketball, I don't care. It's like, that's meaningless to me, man. Couldn't do it before.
Right.
But if I had a stroke and I couldn't think as quickly as I do, and I couldn't speak, and I couldn't use language, I would be devastated. I had a friend who's I still have him, who is a great psychologist. And he I've known him for 50 years. He's always been physically gifted. In fact, when he had a choice about whether he was become a pro athlete or a psychologist, and he decided on psychology.
Hmm.
But he always lived in that gifted kinesthetic, 0.1% range.
Mm.
He came down with Guillain-Barré,
Ouch.
so he was totally paralyzed. And through hard work and luck, after 1 year, he was able to get back 95% of his functioning.
Hmm.
Unbelievable.
Yeah.
But when I would talk to him, he would tell me, in all honesty, that losing that 5% made him kind of average. He lost that giftedness,
Yeah.
and he felt as though he was wearing a snowsuit, galoshes, and a hat and interacting with the world. And it hurt him so much that he was suicidal every day.
Hmm.
He had to come up with a reason to live. What else does he have aside from the memory of being so attuned to the physical world? What else is there for him? And he decided his emotional um, intelligence was still pretty damn good. So he could be unbelievably attuned to other people that he's working with and or that he cares about.
Hmm. That's really fascinating, and a wonderful story. Thank you for sharing that. It's something that I've often noticed with people who become older, right? As we get older, our bodies are no longer as limber and as it used to be. And one of the things or functions we might say that comes from that is this sort of uh, increased internal reflection, right? An increase of potential cultivation of meaning and spiritual systems, right? It brings you back inside to your internal world and engage the outer world in a different way that's not so physical anymore. And it doesn't necessarily mean it's a bad thing, but just that it's a different phase of life. Um, and moving into this sort of spiritual realm, I know spirituality was something also of interest to you. And I think this is maybe the last topic we can really touch on, which is a good one. Maybe you can elaborate a bit on your views and thoughts in relationship to spirituality.
Yeah. Um, in terms of therapy, it's what, there are people who talk about, um, as psychologists, when we try to understand social factors and how they impinge upon psychological functioning, we invoke a term of psychosocial. And there are those people who say that for individuals where spirituality is important, we can invoke something called psychospirituality. What is this person's relationship to their understanding of their relationship to God? And what does it mean? Are there um, any sequelae to how they're presenting in terms of therapy and what's going on? So you can, in a non-judgmental way, when you talk about psychospirituality and working with people, in a non-judgmental way, help them to um, see their relationship in a healthier manner.
Mm.
So, for example, um, I'm sure you've run into it because it's fairly common, but I used to see all the time where people saw their physical infirmity as a punishment from God.
Mm.
And And I've had a number of patients tell me that they're non-adherent because this is a punishment from God, and when God's done punishing me,
Right.
he'll heal me.
Becomes like atonement.
Yeah. So along that vein, what I ask is, so how will you know? What do you think it'll take for God to forgive you and to stop punishing you? Sometimes it's harder than others. Um, I had a young boy who had a number of chronic illnesses, and I was doing a study on psychospirituality, and I knew him. So I asked him, I said, and he was about 7 or 8. I said, "Do you pray?" And he suddenly looked really sad. And he looked down at the ground, almost crying, and he said, "I used to." I said, "So what happened?" He said, "Well, I was praying that I would get healthy, and I never did. So I think God just wants me to be sick."
How did you respond to that?
That was tough because he had a hard life even outside of his chronic illnesses.
Mm-hmm.
Well, do you think if he was older, I would say, do you think um, that God will reach a point where he doesn't want you to be sick? What do you think God wants you to learn from being sick? So I had another young woman who also had a number of conditions. She had lupus, end-stage kidney disease, HIV, and to make a long story short, she was okay with most of her meds, but when I analyzed some of her non-adherence, she refused to take some of the larger pills. She said, "I just can't swallow them."
Mm.
So, okay, there's all kinds of swallowing therapy that I could teach. So I started to teach her swallowing therapy, which in part was helping her to relax, progressive muscle relaxation and stuff. And I knew her for a long time. So we had a very good relationship. And she's relaxing. She's doing a great job. And all of a sudden, when she's really relaxed, she opens her eyes, pops up, looks at me, and she says, "Oh, no. Oh, no. I'm not having any of that. The devil has already had his way with me. And I know if I'm not relaxed, I'm letting my guard down and I'm never going to do that again. Absolutely not." And she goes off on how she's going to fight the devil. And I said, I never knew. I said, "So religion is very important to you?" She goes, "Oh, yeah." And I said, "So you read the Bible?" She says, "Every day." I said, "So um, what's your favorite passage in the Bible?" And it was kind of the Serenity Prayer. And I said, "So let me ask you a question. Do you believe that God wants you to be better?" And she thought about it for like a minute. And she said, "Yes, I do. I think he wants me to be better." And I said, "Do you think that one way you could get better is to take the pills?" She said, "Yeah." I said, "Okay, so if you say the Serenity Prayer, do you think the Lord will help you to swallow the big pills?" She said, "Let me try it." So she tried it, and she was able to do it with the Lord's help. But yeah, getting back to your original point, one option as you're getting older um, is to be more aware of the critical importance of your relationship to other people, how you're living your life. And one way to understand that would be within a spiritual framework, which I think brings us full circle, Aldrich.
Yeah.
It's what's the meaning that you're bringing to your life and to how you are conducting your life? Is this how you want to live? because you're the boss. I mean, like, you can live any way you want.
Right. Barry, would you say for you meaning is constructed or discovered or both or something else?
Absolutely both. And it changes as you grow older and as different things become important to you, like becoming a father.
Mm.
Suddenly, all your priorities change.
That is true.
Yeah,
Though I am still here.
exactly.
So, it was one of my rapid fire questions for you, but I might as well, since we're on the topic of meaning. Um, so, do you think, or, well, first of all, do you think that life is meaningful, or both meaningful and meaningless, or again, some other alternative?
Now, one of the takeaways from well being is everybody wants to lead a meaningful life.
Hmm.
Nobody says, "Yeah, I want my life to be meaningless. That'd be great." It's, so then it becomes a question of what does that mean to you? If you want your life to have meaning, how would you know it does? How would you know it doesn't? And what are the things that you have control over where you can change that ratio? On some level, yeah, life is meaningless. The world goes on after we die.
Hmm.
Um, so okay,
So,
what else is true?
so would you say that the universe? Would you say that the universe inherently has meaning, or would you say that humans bring meaning to the
I'm into our brain works in terms of patterns.
Okay.
So we're the one who brings meaning to the universe. The same way we look up at random um, um, the random assortment of stars, we say, "Oh, that looks like a guy hunting a bear.
Mm-hmm. Hmm.
That looks like a Big Dipper."
Here's a curveball for you. So you said that you think humans then bring meaning to the universe, but
Yeah.
do you believe that humans are part of the universe?
Oh yeah.
So wouldn't you say that the universe itself is meaningful?
Actually, I believe the universe itself is meaningless. Just
Mm.
like the stars are a random assortment, and we can make of it anything we want,
Right.
all the way from, um, you know, um, you live, life is hard, then you die.
Hmm.
That's the way you understand your life.
But I guess what I'm saying, Barry, by saying the universe itself is meaningless, you're dissociating yourself from the universe because you just agreed that you are part of the universe.
Yes.
You are also bring meaning to the universe. Do you see how that might lead to the idea that the universe itself is meaningful through the substructure?
Yes. If we make it such,
Okay.
if we make it meaningful, it's meaningful.
Right, right. Okay, awesome. Thank you so much for this interview. Is it okay if we did just a quick round of rapid fire questions before we end
Go
it?
for it.
Okay, excellent. Let me take out this list over here. Okay, first question. Name a book you love. I know
I'm,
these.
no, I'm going to be consistent.
Okay.
Viktor Frankl's Man's Search for Meaning.
Okay. Name a source of inspiration.
John Coltrane.
Okay. What did you want to be when you were a kid?
Um, when, when I was a kid, I thought it would be fantastic to own a delicatessen
Oh,
because then I could have
yeah.
deli whenever I wanted.
That's pretty funny. Okay. Favorite type of music?
Favorite type of music? Um, Blues.
Okay. Name a song you very much enjoy.
Will is Gone, BB King.
Nice.
And as you know, Summertime.
Okay. Yeah. Yeah. Name something unique about yourself.
Wow. I found over the years, I've become to appreciate that I have a talent for building teams of people who have a common goal.
Interesting. Okay, it's good to know.
And it shocks me that not everybody does that.
Hmm.
It's because it's easy
Of
for me.
course, you have a particular talent or gift when no one else sees it, but it's simply easy for you.
Yeah.
Okay, next one. Do you believe in God?
Yes.
Okay. Which is more fundamental to you, consciousness or matter?
Consciousness.
Do you have a favorite philosopher?
Nietzsche.
Who?
Nietzsche.
Oh, Nietzsche. Okay. And finally, what is the purpose, if any, of human life?
I think the purpose is um, to be kind to yourself and be kind to others.
Okay. Well, excellent. Barry Nierenberg, everybody. Thank you so much again for your time and your insight and your knowledge. It was a true pleasure.
This was fun, Aldrich. Thank you for inviting me.
Excellent. Okay.